like to introduce you to Lisa Hutchinson, who is a professor in the College of Pharmacy here at UAMS and works with us at Reynolds and the Geriatric Education Center, and used to be at the VA, and is a good friend and a wonderful presenter. And so, Dr. Lisa Hutchinson.
So I have no disclosures regarding this topic. I have three objectives. I want to look at the molecular basis for developing drug therapy, so you can kind of categorize the medications that we use and what might be coming down the pike. We'll evaluate what medicines are currently approved and talk about their use a little bit, and then also talk about unapproved medications, herbals, and some new molecular entities, and try to give you some tips on how to manage patients with medications. So the molecular basis for these therapies for Alzheimer's disease fall into three main categories: the cholinergic innervation of the central nervous system, amyloid hypothesis, and the neurofibrillary tangles that are produced. And so that's how we'll proceed. The first are the cholinergic hypothesis, and this is a diagram of a cholinergic neuron, and you can see here where acetylcholine is produced by the cholinergic neuron, and then it would go across the synaptic cleft to be picked up by the other neuron and activate that neuron to help with memory and so on and so forth. Then it is actually degraded in the synaptic cleft into acetyl-CoA and choline, and taken back up by the cholinergic neuron and re-assimilated and used over and over again. And so our major drugs for Alzheimer's disease are drugs that inhibit that degradation so that it hangs around in that synaptic cleft a little bit longer. There are four that have been approved in the past. I don't think Tacron is really available anymore. That was the first one. It was required 4 times a day dosing and had liver toxicity. It's been replaced primarily by donepezil and then also rivastigmine and galantamine. And so you see some of the trade names that are used with those. These medications are very similar, but they do have some slight pharmacologic differences. The donepezil can be taken with or without food, whereas the other two, it's recommended that you get more absorption if you take them without food. However, we tend to recommend taking them with food because of their side effects, which we'll talk about in a minute. Another advantage donepezil has is it's preferential for the central nervous system as opposed to galantamine. It is a reversible, non-competitive in its binding, so that the pharmacokinetics don't follow exactly its effects because of that binding. The rivastigmine, the main difference is it also inhibits butyrylcholinesterase, not just acetylcholinesterase. That actually causes it to have a higher percentage of patients with some of the adverse effects. And then last, galantamine also modulates nicotine cholinergic receptors, and so some people thought it might have an edge, but really it hasn't shown to make that much difference. But it is good to know that when you think about nicotine, that this drug is also working on those receptors. This chart gives you the general dosing guidelines. We start at the lowest dose, usually go for 4 to 6 weeks on most of these, so people can develop tolerance to the adverse effects, and then build up to the next dose. And try to build up to a maximum dose if possible, if the patient can tolerate it. Donepezil recently came out with a 23 milligram daily as a maximum dose, which is kind of odd. It was for years 5 and 10 milligrams, and now there's a 23. Very few patients can tolerate that dose because of the adverse effects with the GI tract. So I don't really see very many people on that one, and you don't really get a huge gain for jumping from 10 to 23 milligrams daily. But you might see that, and people do ask about it occasionally. Another important thing to note we do have an extended release of galantamine, and that sometimes can be a problem if people are not aware of that, and like in transitions of care when you're moving from one to another, if you don't have the extended release on your formulary, then you need to divide the dose up if you use the regular release back to twice-a-day dosing. And then last, rivastigmine comes in a patch, and that can be helpful for patients that you have trouble with them taking medications. It also has more of a sustained reaction through the day, so you don't see the ups and downs, and people do seem to tolerate those that increase in adverse effects that I mentioned that oral has. They don't seem to have as much trouble if they use the patch. All of these drugs seem to have about the same effect as far as therapeutic effect. So I just wanted to show you one chart that kind of describes the differences here between placebo, which is here in the red, versus 5 and 10 milligrams of donepezil with the ADAS-Cog. And so this particular measure, it's about measurement of 4 is thought, difference of that is really what's clinically significant. So you see there's not really a huge, we don't see a whole 4 difference between placebo and the drug dosing on average, but we will see some patients that have that difference, and so that's why we still continue to use these medications, is that they do have a statistical significance, and some people have a clinically significant improvement. Now, I've mentioned the adverse effects several times, but think of them in these categories. The number one most common is the gastrointestinal adverse effects, and so these drugs, because they build up the cholinergic system, not just in the brain, but in the body, the GI tract, you may have nausea, vomiting, diarrhea, and you could have increased acid production, which if somebody is at a risk for developing ulcers, that might tip them over the edge to have ulcer disease. So that's the main one that people tend to develop a tolerance to as you use the drug. So that's why we start at the lowest dose, go for about a month, then increase if we can, and they can see if they tolerate those GI effects primarily. The central nervous system will have headache, insomnia, and dizziness, and so we'll many times give the once-a-day drugs at night, thinking that then the worst of the GI effects, maybe the nausea, will be at night, and people will not really be aware that they have much nausea with the drugs. But if the drug causes insomnia, then move the dosing to the morning, and that will usually work pretty well. The cardiovascular system, these drugs will cause bradycardia, and if you think back to some of your pharmacology, we've used the opposite of this, atropine, to speed up the heart. So it makes a lot of sense that when you actually use a cholinergic drug, that would slow down the heart. And about 10% of patients will have significant bradycardia. And there's actually been studies that showed increased insertions of pacemakers in patients that are on cholinesterase inhibitors. You can also have, if somebody has syncope, that is considered an important reason to not use the medication, that the risk would outweigh the benefit. And it's on the new Beers list to not use the cholinesterase inhibitors in individuals at risk for syncope. On the GU tract, urinary incontinence is pretty common, and then I'll see when somebody develops that we'll sometimes see them started on an anticholinergic medication to deal with that, but then you're probably negating the effect of the cholinesterase inhibitor. So it's really not a good idea to do that. And if they have significant urinary incontinence, then think that the drug's probably not, the risk is probably not it's too high for the benefit. And then last, there are drug interactions with the cytochrome P450 system, the 2D6 and 3A4, so just be aware of those because many of our patients are on multiple medications. There are some controversies with the use of these cholinesterase inhibitors, and here I'm going to go through each of these separately. So there has been a trend to see these medications used in mild cognitive impairment. There was a good study that showed donepezil that was tried along with vitamin E that was studied in mild cognitive impairment to see if they could prevent the progression of those patients to dementia. Where they would get that diagnosis of dementia. And donepezil did slow some progression in year 1, but it did not persist. And so I have seen a lot of patients that have been tried on donepezil in mild cognitive impairment. And that was in 769 subjects, then compared with galantamine that was tried in a couple of trials that actually increased the risk of death in those patients, most of them due to vascular causes. So right now the jury's still out on whether that's really beneficial overall to treat somebody with one of the cholinesterase inhibitors when they have mild cognitive impairment. Another concern is how well this drug works in moderate to severe disease, mild to moderate disease. And we have good data on the moderate to severe here, and we tend to use it most often. in mild to moderate disease, and then further on, some patients with moderate to severe disease will be continued on the medication. This is a disability scale for patients with Alzheimer's dementia. It does show some benefit, although this is a 40-point scale, and so you can see a little bit greater effect here in the more difficult patients with donepezil. Another question is, how long does the medication continue to work? And we've got some studies that go for a year that show that there's continues to be a separation for a year, and I think I have one also that shows a open label study that went for 3 years with galantamine. And so we still think that over time that these medications do produce an effect. And so once somebody is started on them, if it's decided that they are effective in that patient, then it's worthwhile to continue them for multiple years. Some people have asked which drug is better. We don't really have the true answer for that. Most people think it's a class effect. There have been a couple of head-to-head studies, but you can't really put them together because of the study differences. You can't do a meta-analysis. But in general, we think they're no different from one drug to the other. So any of them could be used and expect the same types of effect. Okay, so the amyloid hypothesis is the second type of mechanism that our medications for Alzheimer's disease work by. And there's 3 ways that we think medications can influence the development of the amyloid plaques, and by clearing the amyloid beta peptides, or by inhibiting their production, or by reducing their toxicity. And so this is a diagram that shows the where the amyloid beta proteins are laying down and are toxic to the neuron. And up here it shows where the beta secretase, the alpha secretase, and gamma secretases would break off the smaller amyloid beta protein, which is the toxic protein. And so you can kind of look through this and see some of the different ways to maybe affect that mechanism. Our other main drug that's already on the market is memantine, and it's thought that it does work by preventing some of the toxicity of the beta amyloid. It is an NMDA receptor antagonist. It's approved for moderate to severe Alzheimer's disease. It's thought that the beta amyloid plaques disrupt the transmission of glutamine, and so this drug works to improve that transmission of glutamine, although its overstimulation is toxic to neurons, and so you have to be careful not, with certain medications not to overstimulate. So this one just sort of modulates it in order to allow the glutaminergic process to occur, but not to be overstimulated. It's dosed 5 milligrams daily at first, and then titrated up to a maximum of 10 milligrams twice a day. And it has adverse effects that are kind of generalized, but dizziness, headache, constipation, and confusion are the most common that are reported in trials. So here's a diagram of the effects. These were studies that looked at moderate to severe patients, and show some effect of memantine versus placebo, as you see, although it's not great. It's moderate effect at best, and so just be aware that you're not expecting patients to really turn around. It's not a cure. The current controversies with memantine are whether we should use it in combination with cholinesterase inhibitors, and if it's effective in mild Alzheimer's disease. The combination therapy, we really only have one study, and it's from 2004, but these were patients on donepezil that were then added on memantine, and these were severe patients, so they had the severe impairment battery and the activities of daily living inventory that were used. And you can see a difference there. It was significant, as you see with the p-values on the bottom. So you can use these together. Many times you don't necessarily see a big difference, but there are some patients that might respond. On the other hand, in mild to moderate dementia, there's been several studies where one came out at first, and we thought it was favorable to use memantine in mild to moderate disease. But then later, as other studies came out and didn't show a difference, and a meta-analysis came out now a couple of years ago, you can see here where you combine the information from all the studies. If you looked at mild to moderate disease, it starts to look like, well, maybe it's going in the right direction, where it favors memantine. But when they separate out those that just had moderate disease, which is a group that it's already approved for, that's where it was starting to show a benefit. And so at this point, mild disease is not thought to really benefit from memantine. So I want to just mention a few drugs that have been tried and are maybe still would come up in various places where you might hear of people trying them for memory disorders. Statins have been talked about as maybe preventing Alzheimer's disease. There's not clear evidence there. It makes more sense that they would prevent maybe vascular dementia because they would prevent maybe strokes from occurring. But that's sort of not clearly defined that those are going to make a difference for Alzheimer's disease. Hormonal treatments, we tried estrogens, but all the studies that came out a number of years ago started to show us that actually women that were on estrogen replacement therapy would have increased occurrences of Alzheimer's disease, and so that's really not panned out. Testosterone has been batted around because, and when you think about both of these hormones, when people start losing those, they do have a change in how they're thinking, and so it makes sense that we would try them. But at this point, we don't have any evidence that testosterone replacement makes a difference. Because of the other adverse effects of estrogens, raloxifene has been tried as a potential replacement for it that might affect Alzheimer's dementia, but the studies have really not been completed with raloxifene. And then nonsteroidal anti-inflammatory drugs have been looked at because there is some inflammation going on as those cells in the brain are being killed by the amyloid beta. And so there were various studies with currently available nonsteroidals that you see listed here. Generally, patients did not tolerate the doses that were being used because they had too many GI effects. And celecoxib, which we thought might, obviate the GI effects, but it didn't have any effect on Alzheimer's dementia. There was an investigational drug, flurbiprofen, that also went through that same mechanism but had less effect on the GI prostaglandins. And again, though, it was sort of fallen to the wayside and is not being used in any country at this point for Alzheimer's disease. Dietary supplements, I also get questions about those quite often, and these are the three most common. So vitamin E, we used to tell everybody to take that. It was like the drug that was going to prevent you from having heart disease and Alzheimer's disease and all kinds of other diseases. But as the studies where we replaced it with our manufactured vitamin E have come out, we start seeing these fall to the wayside. And so this is a particular study where they were looking at several things, donepezil, vitamin E, the combination, or placebo, to see if people with mild cognitive impairment did not progress to Alzheimer's disease. And really they were not able to show any difference with placebo and vitamin E. They just kind of follow each other. This is the group here that had a genetic predisposition to Alzheimer's disease with the ApoE, and up here there was no statistical differences where you just looked at all the patients involved. So right now vitamin E has fallen out of favor completely, and there have been some studies that indicate that it might worsen your risk for Alzheimer's disease. So we don't use vitamin E. That doesn't mean that eating fruits and vegetables and other things that have high amounts of natural forms of vitamin E wouldn't help. We might still see that in the future come out as an improvement, but actually supplementing with the manufactured version doesn't seem to make a difference. Ginkgo biloba is touted to help with memory, and people take it before they're taking exams and that kind of stuff. But over 130 randomized controlled trials have been done looking at memory and Alzheimer's disease, and none of them are showing a definitive answer. The question is, again, is it something we're doing with the manufacturing? Because of the 130 randomized trials, you've got, 800 probably, no, not 800, it would be 8 different types of ginkgo biloba actually being used, and then the analytic concerns of the production. And so I just included here, again, a meta-analysis that tried to look at any of the memory tests, and they've all crossed the 0 here, where it showed no difference. So there was no difference for Alzheimer's disease or other memory tests. Now, the kind of the new kid on the block is curcumin, if I'm saying that exactly right, but it's from curry spice or turmeric, which we're familiar with. And there have been some epidemiologic studies that compared people that had high consumptions of curry versus those that did not with their MMSE, and it seemed to be protective, where they maintained their MMSE scores higher. And there are in vitro studies that might support this. It give it a mechanism where it showed enhanced uptake of the amyloid beta protein by macrophages in the cells that were treated with curcuminoids. And so it may be that this one's going to turn out to be helpful in preventing Alzheimer's disease or in maybe treating it. So you might, think about if you want to change your diet, there might be another way you would want to change it. But right now we don't have any placebo-controlled studies. We do have a number of investigational agents. The most information is available right now on these drugs. We're looking at drugs that affect some of the immune status in the brain. Etanercept, or Enbrel, which is on the market for rheumatoid arthritis and other similar type diseases, has some case series from a physician out of the California area that had, he was injecting it perispinally so that then it would be taken up into the central nervous system and reduces the tumor necrosis factor, and that's how he kind of came up with the idea to do it. And he's got some case series, and I've seen some videos where it seemed to make a difference in his patients. But he's using it like once a week, and normally, like in rheumatoid arthritis, it's once a month or later. And so it's very expensive. It's, of course, not supported by any insurances, and so we need really that study that's going to say whether this is really going to work or not. The other drugs that you might hear about are amyloid antibodies. And so there's 3 different ones from different companies, and I'll talk a little bit about how those have come about. And so some of you may remember, it's been now over 12 years ago that I heard was a mouse model for Alzheimer's disease that were treated with a vaccine that would prevent the formation of the amyloid beta peptide, or would help clear it from the brain. And I mean, people were saying the mice brains were like, completely clear of these plaques. And so they just thought we had the cure for Alzheimer's disease, and they were very excited. And I was also very hopeful. However, then as they developed the vaccine and for use in humans, in human trials, we had, unfortunately, 6% that developed an aseptic encephalitis. And so that became, too risky. We can't really use that. Now, of those 300 subjects, they still followed them years later, and they were able to show some effect of the autopsy, where you had some clearance of the amyloid plaques. And so it's still thought, well, maybe this is a mechanism that we can go after, and they've turned to the antibodies rather than the vaccination as a way to help clear the amyloid plaques in humans. So we're seeing those studies being done. The third mechanism that drugs might use, that might be targets for drug therapy, has to do with preventing the neurofibrillary tangles through stabilization of microtubules or kinase inhibitors. And again, I have a little cartoon here that kind of shows where some of the drugs might be working if they prove effective. However, we don't have any on the market right now, and so you might see those in the future. And I've got kind of a summary here of what drugs are in clinical trials. This was developed in 2011, and some are unknown mechanisms, whereas some work through the amyloid, some through mitochondria, and through the tau proteins. So we might see these, the phase 3 ones, you see several of the immune globulin, of the antibody type ones. So maybe those will come into play pretty soon in the next few years. We are hopeful for that. So So I want to turn now, those are the kind of the drugs that are, focused directly on Alzheimer's disease, but as y'all probably know quite well, many patients develop as they progress with Alzheimer's disease to have behavioral and psychological symptoms. And so that's the other area that we see lots of drug therapy used, but we don't have a whole lot to hang our hat on. But this slide here just sort of shows you some of those psychological and behavioral symptoms that may occur around the diagnostic time of Alzheimer's disease. So many of those might be something that we'd want to use a drug for, but right now we have absolutely no FDA-approved drugs to treat any of those complications of Alzheimer's disease. And so what we've ended up doing is, trying to cobble together some things to see what might work. So I've got a table here that is a compilation of things from various, not really good studies, but some studies, small studies, some open label, some presentations I've heard and been part of where people have suggested what we might try if we wanted to use pharmacologic therapy for some of these behavioral and psychological symptoms. So obviously, depression, you would think of an antidepressant. It is suggested that you treat depression if an Alzheimer's patient has that diagnosed, and up to 80% of them will have depression. It's recommended to use an SSRI or mirtazapine, which mirtazapine is helpful if they have trouble sleeping because it will cause some drowsiness and you can give it at bedtime. The SSRIs that are preferred generally are like citalopram and escitalopram because they have the fewest drug-drug interactions. If you think the patient's showing paranoia, which is actually one of the symptoms that was described in the very first Alzheimer's patient that Dr. Alzheimer's presented, they start thinking people are taking their stuff, or they're thinking that because they don't understand why you're going off into a room with somebody else without them, that you're, maybe you're, if you're the spouse, that you're having an affair with somebody else. There's things like that. They're always, they're starting to be accusatory of these things, and it's because they can't understand what's going on, or they can't remember where they put stuff. Some people will use antipsychotics. They're indicated sometimes for moderate to severe symptoms if you really can't get a handle on it with non-pharmacologic treatment. Hallucinations will sometimes occur with delusions or psychosis. Now, if there are things that don't bother anybody, it's better just to let them have those and not treat them because it's really not affecting the life. But if, it's causing a problem because they're again, paranoid, or because they think people are out to get them or something, then you do generally have to treat them. These patients are very sensitive to antipsychotics, and so we tend to use very tiny doses of risperidone, olanzapine, or quetiapine. And then we would rather try a little dose and then watch them for a few hours or a day and then titrate up very slowly. Apathy is one of the symptoms that I hear about people complaining about, but we've never really had much to do. It's one of the earliest symptoms. We try to tailor activities that person would like. So if they were a big football fan, then try to get them involved in watching football, even if it's the old reruns from that are shown on some of the ESPN classics or something. Try to get them involved in things that they have always enjoyed. There are some investigators that suggest cholinesterase inhibitors if they're not on one, to try a cholinesterase inhibitor. And one of our investigators at the VA is using methylphenidate and modafinil and has tried it in some short-term studies that seems to be effective. So they are toxic medications, and elderly people have, of course, more risk for those toxicities. So just be aware of that and watch for them carefully if you do see those being tried. Insomnia is sometimes a problem. They tend to sometimes get the sleep-wake cycle messed up. They'll be up all night, and then they sleep all day, and the caregiver is up all night with them, but then they can't sleep all day because they got to do all the other caregiving things. So we try to look, is depression part of that, or if not, maybe if it's the sleep-wake cycle, how do we get them back into the right cycle? Sleep hygiene techniques are frequently helpful. Melatonin has sometimes been used in order to try to normalize that cycle. So giving a melatonin at bedtime when the normal bedtime would be might be useful. Anxiety is a symptom that is partially caused because they can't find things or can't remember things or they can't understand what's going on, and so they start getting anxious and can't understand. So buspirone is one of the least toxic medications that we have. You could try that. I don't see it used very often, but I think if somebody has mild anxiety, it's very useful there and would be worth a try. But most of the time, people have not really complained of the anxiety when it was mild, and it waits till it's built up to where it's moderate to severe. And so then you feel like you need to use something stronger because buspirone doesn't work as well on the more advanced anxiety symptoms. So an SSRI or a SNRI like venlafaxine might be useful. We try again to use like citalopram or escitalopram because they have the fewest drug-drug interactions. But those are very useful for anxiety. Gabapentin has been used. Not a lot of data there, but it is renally eliminated and it doesn't have a lot of drug-drug interactions other than causing drowsiness, so that's a possibility. We do try to tell people not to use benzodiazepines because we know that's going to add to the cognitive deficits and they're going to get more confused, and you end up just giving them so much that they sleep all the time, and that's really not the goal, is to use a chemical restraint. Sundowning is also a common situation as the disease progresses. It's any time of the day actually after 4 p.m. because, of course, the sun starts to set around here at 4 p.m. These days it feels like it's not quite that early, but it's thought to be related to, the shadows and the loss of, you don't have a good 12-hour cycle of day versus night. And so many times we will see low doses of an atypical antipsychotic used if we can't handle it with other non-pharmacologic means. Wandering, I've been told by many people that no drug will stop wandering. They've not ever seen it work unless you're giving so much that they can't get out of bed. So if they, again, that's not our plan. That's not what our goal is. And so we just need to find a safe place to walk. And I've seen nursing homes that painted arrows on the floor or a line, and that was a safe place that people could keep going around and around. You do have to be careful and don't make too many changes. I saw a video once where somebody had this path that they were used to walking, and then somebody put a fish tank aquarium in the path, and of course that was not something they could understand, and so they were trying to go around the backside of that aquarium and cause a great consternation. And then last, aggression. This is kind of the most difficult. It's hard, you're trying to help the person and then they're aggressive and biting or spitting or whatever. But this is where we do try to use non-pharmacologic measures as much as possible because we have no data that the others work for long term. If they're in danger or they're causing potential danger for their caregivers, then an antipsychotic might be indicated. So just to kind of review some general management strategies that I would suggest for pharmacology is, first of all, let's look at other things. We don't have a whole lot for Alzheimer's disease, so let's do what we can with everything else. So always look at their comorbid conditions. So do they have cataracts that we could do? And try to do these early in the disease when they can, be a participant in the decision making and understanding. So remove cataracts, make sure they have their glasses, get them hearing aids if they need hearing aids, those kind of things so that they have their senses about them. Or if they have any type of heart disease or something, try to get that managed to be as stable as possible. You want to educate them as well as the family about the disease because, yes, if things go on and nothing else causes their demise, then they're eventually going to need 24-hour-a-day, 7-day-a-week care. And so we need to kind of plan for that as early as possible and deal with those social issues, get the family involved or get a plan involved to handle that in the future when the person is able to participate in the discussion. I always tell people, let's look at their medications because so many times people are started on things that maybe they don't really need long term. They needed them for a month or two and then somehow it's just still there. And so let's get rid of polypharmacy, anything that's anticholinergic, and there's a whole host of medications that just have a little bit of anticholinergic effect, and if you're on 3 of them, well then it's like being on a full-blown anticholinergic drug. So trying to go through those with a fine-tooth comb. And then you can add the pharmacotherapy in the appropriate places, the cholinesterase inhibitors, particularly for mild to moderate disease, and then memantine, more so for moderate to severe. Also, avoid alcohol. That's one concern that, people that might have been used to drinking some all their lives. Well, any amount of alcohol, we can't, every neuron is precious at this point, and so we can't really afford to to use the alcohol even in a limited amount. I mentioned the anticholinergic drugs. I'll just reiterate that. There was a study actually of long-term care residents, and of over 2,000 of them, there were 500 nearly that were on a cholinesterase inhibitor, and of those, 20% were also on drugs that had anticholinergic activity. And so that's really too many. We need to be thinking clearer about that as we're adding drugs or looking at the person's medication regimen. And it's best to avoid any drugs with sedative hypnotic effects. So I mentioned alcohol, I've mentioned benzodiazepines, antihistamines, just anything that might cloud their sensorium, because that's just going to make it harder for them to understand their environment and what's going on. When using cholinesterase inhibitors, it's recommended to initiate therapy early in the disease, because that's where most of the studies are in mild to moderate, and so you can maybe hold on to better activities of daily living and function early on. Titrate to maximum dose, although I don't see many people going above the 10 milligrams to the 23, but you might have, if somebody does tolerate it, it might be worthwhile. Caregivers sometimes expect a lot more response to these medications, and so do try to educate them that there was an early study where about a third of patients had a response and 2/3 didn't have any response, but that 1/3 had enough response to carry the study to give it a positive effect. At 2 months is when you should see, are you tolerating the drug? The GI effects, the bradycardia, etc., to decide if that's worth continuing because of the risk. But at 6 months is how early you should wait. You should not do this any earlier than that to see if they're effective for the person. And if somebody doesn't tolerate one drug, or maybe they're not showing a benefit, it is reasonable to switch to a different one, because maybe they'll have something unusual about that individual that we're not aware of, as far as better tolerability or benefit with a different agent, because they are very different structurally. But if you are having significant adverse effects, don't be afraid to stop them, because, again, the effectiveness it's not that grand. Memantine should be used, we'll see it used when someone cannot tolerate a cholinesterase inhibitor, but right now I'm pushing that to moderate or advanced stage because we don't have any data in the mild studies. It's an add-on to cholinesterase inhibitors as someone progresses sometimes. And again, don't be afraid to discontinue it if we have significant adverse effects. And then finally, the behavioral and psychological symptoms. It's best to try to identify the triggers. So is the person in pain? Are there people that are getting them agitated? Was there a change in their schedule that's kind of disrupted that routine that they have grown to appreciate? Try to prevent those triggers and avoid the symptoms from generating. If you can't do that, then look at non-pharmacologic measures. Just think through, well, how would I like to be treated if I was in that position, and would I like music, or would I like a massage before I go to bed? I would anyway. Sign me up for that one. And then as the last resort, look at the psychoactive medications. So with that, I'd like to open it up for any questions that we might have.
How often do you reassess the medication's effect? I mean, let's say you have somebody that's been on medicines for 2 years, they're not doing well, you take them to a physician and he says, oh, those drugs are fine, that's all the help you give.
Yeah, and actually that's, because these drugs do not stop. Oh, I'm sorry, I'll repeat the question in case somebody couldn't hear it. The question is, how often do you reassess when somebody's been on the medications for a long time? For example, somebody might be going to their physician and the caregiver saying, well, they're not doing very well, and the physician says, oh, they're doing fine, we're going to keep them on these medicines. And it is very somewhat subjective. The drugs do not prevent the disease from progressing, so we still see progression of disease. And so it's how you interpret that. Is the drug helping a little bit with cognition? Even though the disease is continuing to progress, it's just helping it at a different level. And so it's really hard to say. We tend to go ahead, if the person is tolerating and has no adverse effects, continue the medications until they are at some major change. Like, for instance, if they are admitted into a nursing home and have very severe dementia and maybe can no longer recognize family members, and we start to wonder if there's any effect at all. And so we do tend to try to reassess like every 6 months to look for adverse effects and therapeutic effect, but over time we'll see them continued up until the very severe stages of the disease. Okay, we have one here.
I have two questions. Anyway, one question is, you had mentioned melatonin, which is over the counter. So what's the recommendation? Just start at the lowest and then?
Yeah, usually, okay, so the question is about using melatonin, if you want to use that for sleep. And the recommendation is to tend to start at the lowest dose. We usually 2 milligrams. I mean, you probably could use lower doses, but 2 milligrams to up to 10 is kind of the range that I'll see, that I've seen recommended. And so you could, I would start at the lowest, and then you could titrate that up pretty quickly over, like every 3 days or so, you could go to a higher dose if you weren't seeing any effect.
Okay. And then my next question has to do with genetics and molecular. You mentioned, molecular, but are there studies going on here or other places having to do with either the genes that metabolize the drugs or the genes that we know a person might carry that would make them prone or a higher risk for Alzheimer's?
There are some people looking at the genetic predisposition to Alzheimer's disease, but at this point it's not recommended to use that for general practice. It's only recommended to use it in studies where you're trying to make sure this is an Alzheimer's dementia versus not having vascular dementia or others. So it's used mostly in those situations, and as far as I know, there are not any of those studies that really direct you to which drugs to use. So,
okay, because I'm in genetic counseling, we see families that have familial Alzheimer's, but it's not like Huntington's where we know ahead of time. We can't test to know if you carry a gene. So, from what you were saying, people who show mild symptoms, you could start treating, but it's controversial. So really there's nothing for anybody that's pre-symptomatic.
That's right. There's nothing that's firmly recommended. Now there's the one study that looked at donepezil. I do see it used, but it's case by case. And most people, most physicians I see don't worry about if they have the genetic predisposition. They will go ahead and try the drug and see if the person will tolerate it, which, again, you've got a lot of cost involved, you've got adverse effects, so whether that's the right thing, I don't know. But I do see that used some. But it's probably best not to use it. You do want to try to, tell everybody, of course, to do things that will keep them healthy. The things that are going to prevent Alzheimer's, which is, was not the focus of my talk, are mainly exercise, eating a healthy diet. Those kind of things are, epidemiologically seem to protect. But it's, there's so many factors involved.
And thank you so much. This was very clear, and the way you presented it, I really got a lot out of it. So thank you very much.
Well, thank you. Are there any other questions?
Are there any food interactions with the medications for Alzheimer's?
The only interactions that are shown have been with absorption. You do have a little less absorption with the rivastigmine or the galantamine if you take it with a meal. And so we tend to say you'll get more absorption without a meal, but it's not known if that's really significant, and if somebody has adverse effects where they have nausea and vomiting, a meal might help prevent that, then it's worth giving them with a meal. But we don't have any of the problems that are seen with like grapefruit juice and now I've seen cranberry juice on the list too for some problem drugs. So.